models of care. So we're very privileged to have her share today. So welcome, Mel, and I will hand it over to you.
Morena, everyone. What a pleasure to be here for the next 45 minutes. I will just briefly introduce myself as well, and then we'll talk about what we are going to cover. Ko Wai-o, no Namibia aho, ko Table Mountain, te Maunga, ko Swakop River, te Awa, ko Atlantic Ocean, te Moana, ko Cape Town, te Turanga Waiwai, wa Ihaho, kei te noho o kei Kaipara, ko Henry Rawa, ko AJ Tamariki, ko Maljua Takuingoa. I'm the program director for the Healthcare Home, part of Collaborative Aotearoa. It's a pleasure to be here today. There are many people here that I already know, so great to see you. Also, before I go into our content, mihiing to our collab team who Amjad, our CEO, plus many other whānau are on their study tour travels. I don't know whether they've arrived in Canada yet or not, but they're all on their travels. So just thinking of them this morning. And all the other people who came before us in terms of building the work that we're going to go through today. So what I'm going to do is cover a little bit of the history of the healthcare home model of care, where it came from, talk about it in terms of just the 4 domains and, you know, what is it, and then really bring it into the context of what we see when we go on the ground and talk to general practice today after 2 years or 3 years of a global pandemic, what's changed for them, what's working and what's not working. So we sort of finish on those notes. And next week, we will be doing a deeper dive into proactive care, and the following week into collective impact, I think is collective action is the 3rd week. So there is quite a lot of content here, and because there's such a high number of people, you know, you're welcome to stay camera off if that's what you're comfortable with, but we will stop at certain points to give you a chance if you've got any questions. I will also give Carol an opportunity to talk from her many years of clinical nurse leadership perspective, and having coming into a healthcare home with those sort of 30 years behind her. So we'll try and cover lots of ground in 45 minutes. Just to ground Collaborative Aotearoa's mahi, and talk about where we get our information from in some senses, and how we know what we know, because we have a huge network of general practices who are sitting under the umbrella of our PHO membership base. And you can see we gather data around the proportion of total enrolled population who are served by healthcare homes. So that's a picture of our membership base, and really our mission and vision in terms of our mahi is very grounded in on the ground practical implementation, both from the past in terms of healthcare home models of care, and also now working with whānau, and Jazz will talk a little bit about that right at the end of the session today. And that, again, that's a subject that we cover in a deeper dive. And I think what's also worth just reminding and kind of grounding us in is a very core equity focus for Collaborative Aotearoa. So we're always looking at that true north, and looking to accelerate change through collaboration and being a catalyst, and, you know, sharing and so on. And I think also the other key thing to say, which a lot of people who know our mahi, is we put whakawhanaungatanga, or connections and relationships, right at the heart of that work. So even today, though I'm going through a lot of, you know, information quickly, if we were running a smaller peer session, we would spend time getting to know each other and supporting each other in the mahi. This is, I think, a useful slide, not only to see that the healthcare home model of care has been adopted in Aotearoa for more than 10 years now by more than 200 practices, and those are the ones who are so-called healthcare homes. There are practices out there who do elements of the healthcare home, so it's 20 to 30% of general practice in Aotearoa have implemented this model of care, many of them prior to COVID. There have been some more recent implementations, but a body of this work has happened, you know, over the last 10 years. This slide also talks about Collaborative Aotearoa's journey, how we came together to share and facilitate as that learning really accelerated. And that's still the case today, particularly around workforce. So, you know, the need to share information across the country. And indeed, the other thing it's worth talking about is that there have been more than one evidence-based review. There is lots and lots of evidence that's well documented that the model of care brings benefits, which we'll talk about in the next few slides. And I like to just frame the model in the grounding of 20 to 30 years worth of evidence-based research and understanding around what are the building blocks of primary care. In this instance, I'm referring to Barbara Starfield, and I think what's useful about those building blocks, which came before Healthcare Home, is that when you look at the basic building blocks or concepts, and sometimes the words are different, but that the ideas are still the same: continuity of care, comprehensive care, patient empowerment, using data, leadership, change capability, all of those things were known and understood. And, you know, I think the other thing it's always worth thinking about, particularly if you're in general practice, is that this is a journey. So some of what I will talk about may well be on that journey. You know, it's kind of come from that place and moving to a future. To just then say, well, if those are the building blocks, how does the Healthcare Home model of care represent those building blocks? Or, you know, what does it do about those things? And this particular slide is the 4 domains. And going back to 10 years ago, one of the narratives that was being used when we first looked at this model of care is that if a general practice is offering one service offering, for example, 15-minute GP appointments and nothing else, then it won't be serving the needs of its population. It's possible that it won't be serving the needs for those who need it most. And the Healthcare Home model of care took those building blocks, but also did work with Kaizen or Lean in Seattle. So Group Health visited Boeing and took the Lean principles of flow and waste and applied it to how general practice works using the principles of the building blocks. And so what you have in the model, and I'll sort of talk through over the next few minutes, is the top left-hand domain saying really have a process which involves knowing demand and having capacity planning and doing data measurement. Have a process that is good for the patient and for you to manage unplanned demand, which can also be described as same-day appointment requests. And that's not necessarily only acute care. It could be same day from the patient's point of view. So it could be a WINS or certificate. So have a systematic process. And if you do, then you are in a better position with the workforce that you've got to use the right workforce for proactive risk-based, risk stratification-based comprehensive care. And that's the right-hand quadrant is where a lot of the HOARA integrated care occurs, as well as the bottom left quadrant, which is routine or preventative care, and the screening and what are so-called targets sits in there. But early intervention also sits in there, health coaching, pre-work by HCA. So there's a lot of other, drill downs on that left-hand quadrant. And the right-hand quadrant is lean, and sometimes represented as just continuous improvement. I will present a case because I'm a lean practitioner and I've seen it work in general practice, that I do think lean specifically is extremely helpful to help the workforce take on tools and skills to do continuous improvement and also to remove waste. And I'll talk about that too. Now, we've put equity right in the beginning of that, the 4 quadrants, and that was in fact something that Te Tai Tokerau did in 2016, and Collaborative Aotearoa took on as an express central aim to continuously remind ourselves and ask ourselves, how do we meet that aim? And it will be built into our measures, or it might be built into collective action. And again, we'll make those links later today. This is actually a very old way of representing the Healthcare Home. The key is no longer something that we would use as a branding, but Andrew Miller used it very recently the other day, so I'll be forgiven for that. And the reason why I've put it up here is it presents those 4 quadrants again. So you've got acute, or unplanned demand on the far left. And it, sorry, I'll just go back to that one. And it also breaks it down from a patient's point of view. And we'll come back to this particular slide when we talk about implementing the different domains. I have got a slide here that just talks a little bit about benefits to patients, and then a slide for workforce. And I'm going to give Carol a chance to just add some of her experience at that point before we move on. But what I've done so far is just given you a sort of where's it come from, bit of a history around adoption in Aotearoa, and those 200 plus practices over the last 10 years really represent an enormous amount, and many of you will be them, I would imagine, the ones that are online, represent an enormous amount of learning and agility and workforce development and leadership. And so there's a great deal to learn and understand from that journey and to share, which is in many ways exactly what we're here for. And what those practices have shown is these benefits. And as I say, there's heaps of evidence behind this, which fit very well with the Pai Water legislation outcomes and empower choice and greater cultural freedom and better ownership of data and better, management of holistic needs. So that's been proven and still sits inherently inside the model in terms of outcomes. I think it's also really worth understanding the workforce benefits, particularly when we put a lens of where we are now, and I do that right at the end of the presentation, because the workforce is under capacity as well as very fatigued. And some of these benefits are about using the right person in the right place at the right time, which is actually quite a lean thing, and we'll come back to that. And it's how you get some of these benefits, for example, better management of daily load, significant increase in that use of the word efficiency. I would use it as lean, right place, right time, less waste, and being able to extend a practice team more broadly. Kind of more importantly than anything, releasing time for patients to be able to support in a more planned or proactive way with a greater ability to coordinate. And one of the things we know is that our healthcare system is still very difficult to coordinate. Navigation requires a huge amount of knowledge. And so being able to release the right workforce for that work makes a massive difference to the outcomes for our communities. Carol, I'm just going to stop there for a second. Do you want to just do a little bit of tell us about your experience from a clinical point of view coming into a healthcare home and what that looked like for you?
Sorry, Carol, you're on mute.
Kia ora. I was just saying I came from a non-healthcare home practice into a healthcare home practice, and there were significant differences. I was under the leadership of Mary-Ann Clouard, and of course I worked with Mel Dewar, and so the first thing I noticed was the fact that it was a team and it wasn't a hierarchical system. And so we would get together in the morning and have a huddle, and those are so important. One, for whakawhanaungatanga, as far as the staff are concerned, we check in with each other, but it was really effective in looking at our templates, seeing what was appropriate, looking at the triage, seeing what could be fixed straight away, what could be sorted. So it was a really efficient way of starting the day, and we all knew what workload was happening, and we could adjust those workloads first thing in the morning, so you weren't getting one person being overwhelmed, and it was a very supportive environment. The other thing is that that was really significant for me is that because it was so structured and organised, we were able as nurses to work at top of scope. We had the most incredible support from our healthcare assistants who were able to do a lot of the roles that we would normally do, like assisting GPs in surgery, which is really time consuming. So therefore it gave us the time we needed to do proactive care, to do the unplanned care, because obviously in general practice there becomes you can need to stop what you're doing and deal to the acute care. But I just found it was so efficient. And the other thing about working at top of scope for a practitioner is that it's so satisfying, and your job satisfaction is huge, and there's so much opportunity for learning and pathways for learning because it's organised. And I think the reason we continue to look at the healthcare home model is it works, and it works efficiently, and it's yeah, it's an opportunity. The other thing that was really beneficial within that model is we actually had a change management team, and that you know, we were working on the practice rather than just kind of a reactionary kind of environment. So we were able to look at access, we were able to look at having an evening clinic, which meant that those who were willing to participate in that staff-wise were able to reach some of those patients who could not get there. Our truck drivers, our small business owners who could not get there for their diabetic checks, and we'd have a practice care assistant with us in the evening as well. So lots of that proactive care was actually being done where at a right time and right place for different of all of our patients. So we were able to increase our productivity, also meet those patients who could not get in, who could not afford to take a day off work to come in for a smear or come in and get their CVD check. So there we go, Mel. It would, yeah.
Thank you, Carol. Heaps to think about. I forget about all the things that we've done. Thank you. Okay, I am going to go into the business of clinical triage, which is one. So we're doing a little bit of a dive into the top left-hand unplanned care domain of the model, and just go through some of the kind of basics. So some of you will know this. There are practices who've been doing this for years. Some have did it, and then COVID came along and it slipped back. And there are also some myths about it, which is why I'm just going to take you through, you know, the clinical triage process according to the healthcare home model of care. And what I would also say is that I did pinch these slides from Andrew Miller, who is a GP at Bush Road. He is currently on our study tour. He presented together with myself and Carol at Mahi Tahi, the Te Tai Tokerau PHO, a couple of days ago, and he had these lovely slides, and I was like, oh, Andrew, can I have your slides, please? So this is Andrew's view as a GP in a practice that has been a healthcare home for 8 odd years, that has a relatively high population. I think it's 14,000 enrolled, and yeah, they like many of the big practices, they would say we cannot live without it. So why would you? And it's partly to do with capacity. In other words, using GPs or other workforces at the right time for the right reason, and in person or not. So particularly the use of prescribers. But it's also got a number of patient reasons why. And one of the things I think is a very simple patient reason is that if you know that you can resolve up to 30–40% of what patients need on the phone, why are you asking them to drive in? Especially these days. So I think, you know, thinking about it from a patient point of view is also really important. Clearly, triage is a word that is widely used, and sometimes it's misunderstood in terms of how it's applied in the healthcare home model of care. It really is there to improve the patient and provider experience, as I said in the last slide. But one of the myths that exists is that the more GP consults you have, the more money you make, and that is actually a myth, because capitation just covers roughly 3.5 visits, and even if you're a non-BLCA, you're still going into loss with high utilization. And one of the things to consider is also, are the right patients having high utilization, and with which member of our workforce? So the reason why we clinically triage is to make sure that we do match up provider with patient need at the right time for that patient's needs and life, as opposed to the system deciding when. And even smoking cessation, you know, is a good example of the system deciding when. And one of the things, a narrative that used to be said about clinical triage is that in the old model, who decides whether the patient gets an appointment or not that day? And usually it's the patient and a receptionist. And then the receptionist may be very experienced, but they're still the one who decides. And what they can't do is resolve on the phone. So they're unable, for example, to prescribe. So this is a quick little picture of the healthcare home maturity matrix, which is a detailed matrix for every domain, and something we can share. It's in, on our website. This talks specifically around unplanned care, and it shows a progression from, very occasionally triaging using nurses, which is a kind of classic general practice model, or to systematically using prescribers to triage same-day requests. And as I say, many practices are on a journey, but one of the things we do know is that from a patient point of view, consistent experience is what means that patients find value in the triage process. If it's an inconsistent experience, that would be very confusing. And it also means they can't rely on it for what they perceive as is important on that day. So you do need, it does need to be reliable. And making it reliable is quite complex. I'll come to it shortly. So this is a picture of Doctors Tiki Punga, good old Doctors Tiki Punga, in Whangarei, pre-COVID, I think in the early days. And the red dots are where patients had called from and had their call resolved. And it makes the point that I was making a few minutes ago, really driving and or having to make childcare arrangements and get to a practice can be difficult, particularly in rural areas, and at the right place and time. So it's not always the right place to do telehealth or to resolve on the phone, but when it is, and we do know there is a time when it's the right thing, it is hugely beneficial for the patient. And with e-prescribing, you can drop off the prescription in their local pharmacy. They really don't need to go very far, even though they live rurally. So it's massively important. It becomes even more important when the routine appointment is more than 2 weeks out. And so I'm starting to talk about kind of proactive and preventative care versus unplanned. And what we all know is that particularly as demand grew, unplanned care can dominate a practice so much that routine appointments are 3 or 4 weeks out. It's also an outcome of not enough GP capacity. It's just starting to rain here. I might, when I give Carol a chance to talk, I might put my headphones on. Okay, 25 past a bit of moving along. So you saw the key earlier, and on the left-hand side is unplanned care, in other words, doing clinical triage. And the point of this particular little picture is that it also enables some other things in the proactive and preventative quadrants. And one of the things we've seen with practices who did do good triage, maybe COVID pushed them back, and then these things drop away as well. So that's kind of, there's a knock-on effect is the point I'm trying to make. And also, for a patient to get a consistent experience of a phone back from a prescriber within an hour, on the practice side, a good understanding needs to be had of how many phone calls we'll need triaging and what's the rate of resolution. And so this is just a picture of that data, which is a really important component of making triage reliably work, particularly when the demand levels change. Can you still all hear me okay? That's nods. Yeah, starting to really pelt down here. Hey, I might actually, well, I might just stop there for a minute. Carol, do you want to say something about triage? And I'm going to put my headphones on, and then my sound should be better.
Just turning my mic off. Yeah, so when we use triage, it's usually started to come up to fill out by the beginning of the day. And a lot of those things might be things that we can give to other people, like our social workers, or the nurse may be able to come in and take some of that acute demand off that are easily resolved, that say that are not needing a prescriber. So again, it's a shared piece of mahi, and like on a Monday morning, we can have, like you can see here, I'm not sure if that's the slide, but Mondays are usually very full with triage. So by looking at the data, you can actually make sure you've got enough people matching the demand of the week. So normally Monday is very high in triage after the weekend, and so those are the times that we need to make sure we've got the right staff. And sometimes a nurse can pop on triage and go through and select the ones that for example, unless they're a nurse prescriber or a nurse practitioner, and they can choose the ones that don't perhaps need to be necessarily called by the GP. You right, Mel? You ready to come back on?
I am. Thank you so much. That's, yeah. And what Carol's also reminded me, because I've not given you heaps of data here today, is we do know nationally, using an advanced form for all clinical triage calls, that the resolution, if the call is made by a prescriber, and that's a GP, or it could be a nurse prescriber or a pharmacist prescriber, the resolution is anything between 30 and 50%. And that's because a lot of it is repeat prescriptions, but also paramedics, for example, can have a high resolution, and certainly, as I say, any prescriber will have a high resolution on a triage list. I think what's worth just differentiating briefly, because there is confusion, is in a practice that is not adopting this particular triage model, what would happen is, let's say 10 acute appointment slots were reserved for patients who needed an appointment on that day, and let's say 20 patients called. The first 10 would get them, and the next 10 would be triaged by nurses. That's kind of the old model. Those nurses will not necessarily triage them inside an hour, and they will not necessarily call them back, so that they would be lumped with all lots of other things that nurses do. And what would happen is that the nurses would probably have to get a prescriber to finish the work. There might be a standing order scope, but it does become double handling. It can also be really demoralizing for nurses. And so it's why we know that for a prescriber to make those calls, particularly during the peak point of the day. So for example, Bush Road have GPs on from 7:30 in the morning till about 11 o'clock in the morning. They're rostered on for triage calls. They will cherry pick based on ethnicity and or chronic or acuity. And nurses will look at it sometimes from a health and social care, and of course the practice also has HIPs and health coaches. So there's a lot of different kinds of workforces who can prioritize that list, but there are prescribers lined up to make calls inside an hour, which have a resolution. And what that does mean for the GPs and nurses and other workforce who are sitting there getting appointments, that's the right appointment at the right time. So for example, a prescriber can make a triage call and then automatically organize a HIP appointment. So not every person has to see a GP first before they see the HIP, right? If you see what I mean, which it wouldn't actually work in terms of GP capacity anyway. Anyway, I'm going to move on from triage. I beg your pardon, I went too quickly there. So this is just really a patient journey, making some kind of technology and workforce points in the flow, really with an idea that the person has ownership of their own health data. They might have health monitoring of some sort, so that could be a smartwatch, but it could be going to the pharmacy for blood pressure. They may or may not be supported by some sort of a Kaiafina, and they might access primary care, ideally by phone and or by patient portal, and or obviously being able to walk in and get a choice of channel and a choice of workforce. And if that's the future, from a organizing a practice point of view, it does require better thinking around flow, capacity, standards, processes, technology, data, and I will cover a few of those things. What we just sort of segueing into digital health, what we knew with some of the data analysis that Collaborative Aotearoa did before COVID was that those practices who were adopting the model of care, one of the components of the care is to sign patients up on patient portal and to become active users of both allowing appointments to be booked, but also manage my health email traffic. And some practices have Indice, and it has its own patient portal. We absolutely saw a huge adoption pre-COVID. I think what happened during COVID is that a lot of practices closed down that communication because the screening tools weren't quite there, and maybe even when the screening tools were there, it still wasn't, it wasn't easy to manage the access if you have many access points. So we haven't somewhat slipped on that, and I see practices picking it back up again now. I also wanted to talk, and I might give Carol a chance to say a couple of words, and I'm watching the time. Just to tie in unplanned care and supporting resolution on the phone on the one hand, and on the other hand, right place, right time for what patients need, means that nurses can move to this
wider scope, which is sitting around comprehensive care and working with integrated teams. And one of the things we saw across the country from an early stage was the introduction of first healthcare assistants. HCAs was kind of one of the first things that came in. Some practices had things like social workers or mental health credentialed people. And then HIPs and health coaches came in. And now we have a wider, pharmacists, paramedics, kaiafinas, care coordinators. It's growing and growing. And the model itself makes it possible for those teams to start working as teams. But if unplanned care is not well managed, especially nursing, get pulled into it. And so some of that kind of gelling that goes on around proactive care suffers. I am going to briefly touch on micro teams just because it might be worth just talking about. So one of the things we do know is that as GP capacity has gone down and demand has gone up, because that's what's happened in the last 3 years, triage has become an incredibly important thing. You have to spend more and more and more hours triaging. I know Bush Road spend, as I say, 5 hours a day. I know at Doctors Tikipunga, we had a full FTE. I know people like Broadway was saying a couple of days ago, they have 2 doctors who live remotely but know their patient population who just triage. So there are all sorts of innovative triage models coming up. What we have found is that there has been a loss of continuity of care. So that original idea of you triage your own patients and then you have, some appointments and then maybe you have some longer appointments has kind of lost with the growth of demand and the need to kind of really turn that triage handle. And I think it's worth thinking about. And one of the ways to think about it, and we had experience, and I'll let Carol talk for a couple of minutes. In fact, it was Marianne who initiated this originally, was where you have a larger practice with anything more than 10,000 patient population and something like 10 GPs and, obviously all this accelerated other workforce to create small micro teams that are sort of 2,000 or 1,500 patients each, where there's a team who know that patient around them, not just the GP. It can be particularly helpful if the GP workforce is rotational, and for a practice of any size where GP capacity is difficult, that will be the case. So there'll be registrars, there'll be overseas locums, there'll be a couple of permies who really probably want to retire, kind of thing. And the nurses and kaiafinas and HIPs and health coaches get to really know those people and are connected with the community. And it's, as Carol said, where huddles come in the morning, they can talk about, hang on, and we know this is a woman and she's probably going to need, 2 more things. What's important to these people when tragedies happen, connecting with the community is easier for a micro team to do. And the other thing that Carol talked about, which is a kind of lean philosophy, is a team culture and I've got your back culture, and sort of covering each other's inboxes and triage lists and different parts. Hey Carol, do you want to say a few minutes on that one?
Yeah, in our particular practice, we instigated through Marianne and Mel, we had 2 teams. We had the red and the blue team. And so within that team, we had 3 nurses and 3 GPs on each team. And again, the nurses become the most consistent person in that journey for the patient. And so they get that continuity of care. Particularly, we had 1 GP per nurse, which meant that that GP knew that if they needed to discuss further, they could come to that specific nurse. But they were in a team. So, of course, we all don't work full time. And so we would be able to cover each other and get to know each other's patients. And so definitely it became better for the patients, and they got to know who to go to, and they had the same nurse contacting them. Sometimes not the same doctor, because we do have a very we have locums and people like that, but they could rely on the fact that the same team of nurses would be available to talk to, and we would be the ones that would contact them for repeat prescriptions and things like that. So yeah, that in itself did create a lot of continuity of care. One other thing I wanted to point out, Mel, is one thing we didn't have in that model is our connection with our community, and we were able to bring through into those groups kaumātua and queer into our practice to improve the journey for our patients.
Thank you, Carol. I'm going to move along because I've got 10 more slides and we've got 6 more minutes. This is a little data of routine and preventive care. Many of you will know it, but the point I made earlier is that getting familiar with data and using data to drive action is part of the journey. And primary care, and we've started to flesh this out, is really part of a wider group of people who are supporting patients, including linking to the community. And there are a few slides here that really just talk about change. So one of the things our practices have understood is that learning about change, skilling up and having tools, forming things like change teams, the practices who have come up with all sorts of patient-led innovations are skilled up on this stuff, and indeed have used the principles of Kaizen or Lean, which are ground up. Everybody is involved in change. And I think the thing that I think is important to say about Kaizen is that it helps a practice eliminate waste, because practices will often say, this is all very, very well, but do you have any idea how busy we are? And when is it that we're going to stop to do all of this stuff? And Kaizen actually gives you the tools to do exactly that, to build it. It says start and get better, to build it in the practice to help you take on the right thing with some good, meaningful thinking, and then implement change that actually sticks. And so there's a list here of some of the Kaizen tools, one of them being visual management. So the use of visual boards and standardization, clearly, and things like problem solving. Those are all tools that take time to learn, but are easy, practical, based on post-it notes, based on bringing people into the discussion, based on regularly giving problem solving time, based on seeing problems and being able to express them. So there's all of that. Okay, we've got 5 more minutes. I did want to acknowledge that there has been some changes during COVID, some less adoption on portal side. Some practices are still feeling really overwhelmed around unplanned care. When we look at the data across the country, there is a growth in demand. It's not definitely is. And so most practices, if they have fallen back from systematic triaging, that is probably the first place to start. And it's why we debunk some of the myths around it. It takes a little bit of attention to start it and do it well. And once it's been done well, then again, it takes a conscious effort to say, okay, then we're going to protect time to do this work around community engagement and understanding our patients' needs and being able to meet them more holistically and using a workforce in a different way. And I think that there are, what we see, and I heard 2 days from the Te Tai Tokoro practices 2 days ago, is Te Hiku, who are a huge practice, a Maori-owned practice in Kaitaia, said that before, if they had not implemented the healthcare home model, they would never have got through the last 3 years. They are still kind of clinging on, but in the next year they might not be. So it's not a magic wand. It doesn't solve all our problems, but if you are not doing it, you're probably worse off than if you are. There are opportunities around the PIORA legislation, which makes it possible to work with much greater empowerment with our communities and empower community-led change. And Jazz will talk about that. And there are lots of opportunities in digital technology, so it's not all bad. And that's the end of my spiel. I have put a culture eat strategy for breakfast because improvement culture is a critical component of being able to change and change constantly. So, leadership and cultural consciousness is also a key part of the whole picture. Kia ora, everyone. That was a whistle stop tour. I hope you're still all wide awake. Jazz, or yeah, I'll let Jazz, because we've got, perfectly on time for a very short elevator pitch, but I know we'll be looking at it in greater detail. Yeah, tell us. Yeah, I'll go ahead.
Thanks, Mel. Oh, I'm just going to jump in really briefly because there may be some questions from the group. But yep, there will be a collective action presentation, and that's in week 4, I think, of this series on the 1st of June. So I'll talk more about that. But yep, no, that's amazing to hear about, kind of, I guess, from my perspective, organising mechanics internally will enable some of those outreaching opportunities and really springboarding on the strength and resilience of community, which is really where I'm kind of coming from. So yes, I'm looking forward to doing that, having that conversation with the group in a few weeks. So thank you.
Thank you. I'm just having a quick little look at chat. Does anybody have anything that they would like to actually ask? Gone quiet, and that's fine. There's lots of you on, and it's absolutely fine to just note your questions. And obviously I'm just wondering, we will make the slides available probably on our website, and you'll be able to contact us there if you wanted to ask any further questions. I think that is probably it, and we're doing very nicely in terms of time. So I'm going to hand over to Carol to finish us off, but just to say thank you so very much for all being here. Really lovely to speak to you today. I hope it was been helpful. And as I say, it's really just a summary of a body of learning that has gone on across the country for many years. So it's been a pleasure and a privilege to be able to present it to you. Thank you.
Kia ora. I just want, but just before I do our closing karakia, this is a bite size of what we are presenting, and this is it seems like a whole lot of information, but it is really to do an overview, and we can work with you post this as well. So yes, it's exciting. So okay, he karakia whakamutanga, kia hora te marino. Kia whakapapa pounamu te moana. Ki tere te ka rohi rohi e mua tō huarahi. Haumie huie taiki. Kia ora koutou katoa.
Ngā mihi, Carol. Great to see you all. Have a lovely rest of the week. Ka kite.
Ka kite.
And I remember to press stop record. Hey, Renee, are you joining us? You can come and join the collab team.
Oh, well, since I've got you online.
Oh, yeah.
Jazz, Jazz, are you available anytime today or tomorrow afternoon to just have a quick chat?
Yes. How about tomorrow afternoon? Do you want to send me an invite, say at 1 o'clock?
Yeah. All right.
Perfect.
Thank you. All right, then. Take care. Thank you.
Ka kite.
Ka kite anō.
Ka kite.
Ka kite.
I was just checking, Jazz, have we got a meeting at 1 o'clock tomorrow? When's that meeting? Let me just check my calendar. There is something on tomorrow.
Yeah. Is it not earlier? It's earlier at 10.
Oh, okay, perfect.
Yeah, I'm going to be catching up with Cara Lee as well. Carol, I've managed to rearrange that appointment.
Oh, what time's that, Mel?
11:30, I think I booked it. I can invite you if you want to, but don't work extra hours if you know.
No, that's fine. I think it would be helpful.
It would be nice if it was both of us. Yeah, okay.
Yeah, that's fine. Yeah. Is everyone?
Have you got no microphone, Jazz?
I do have microphone, but I can see Katie and Tonia are still
yeah
on.
All right, well, we'll maybe close the meeting and I'll jump online. I think we said 11:30, didn't we, Jazz? I'll see you then.
For you and I, yeah. Do the three of us want to just have a few minutes?
Yeah.
Yeah, shall I reset up another meeting?
Yeah.
Okay. All right.
Sounds good.
Bye.
Thank you.
See you in a
Bye.
bit.